Welcome to the Wild Wild West, folks. We've been making our way on over to the Oregon, but one of our troop members has been beset by abdominal pain. He's an older feller, in his 60s, so good for him. He can't really expect to survive the Oregon Trail at that age, can he? Meet Theodore. I'm done with that. Meet Theodore. While on the real Oregon Trail, abdominal pain probably means dysentery, and, well, game over. But here, we're going to think about the possible causes of this abdominal pain in Theodore and see if we can come up with a diagnosis. So, he's been complaining of pain for the past 3 days in his left lower quadrant, and he's also been complaining of feeling sick to his stomach, and he's been chucking basically everything he eats. And Mal said he's been running a temperature. He's been mighty constipated too. Ugh, you're not good at that, Ricky. Stop it. He tells us that for the past several years, he's been dealing with trouble with moving his bowels and recurrent pain on that same side. He's tender to the touch, and his bowels haven't been making gurgling noises when Doc listens with his stethoscope. There's no peritonitis, Doc says, though. Whatever that means. What y'all think he's got? And to throw a wrench in this here axle, I think we got bandits coming our way. So let's think fast. Left lower quadrant pain, constipation, tenderness? Ah, geez. Maybe there's something up with his colon. And what about that fever? Inflammation? Infection? When we're thinking the colon and a patient is presenting like he's sick and maybe has infection, then we're thinking about popcorn getting stuck in these little outpouchings of colon called diverticul. Huh? What's that? No? Popcorn getting stuck has been disproved? Huh. Go figure. I was about to talk about diverticula. So then, how does the inflammation develop? The colonic diverticula seem like the most likely location of the inflammation causing Theodore's problem. So let's start with those and see if it fits. Colonic diverticula are outpouchings of the colonic mucosa and submucosa through the muscularis, forming a little sac outside the colon wall. So we've drawn in these sacs hanging off the colon wagon, which should look familiar if you've watched the diverticulosis sketch. Diverticula are thought to be caused by high intraluminal pressure, pushing the mucosa out through the colon wall at areas of weakness. And where is the colon weak? The vasa recta are a network of arterial vessels that travel through the colonic mesentery to supply the large bowel. The areas where they penetrate the colon wall form anatomic areas of weakness through which the mucosa can break free. This is why diverticula typically form along the mesenteric border of the colon. So we've brought in these tangly red vines right on the organ border fence. Since the mucosa and submucosa herniate through the muscularis, i.e., not all layers of the colon wall are involved, colonic diverticula are false. The contrast is a true diverticulum, which involves all layers of the wall of the GI tract. For example, a Meckel's diverticulum, which forms during embryogenesis. Oops, better watch that wheel, people, or this wagon's gonna take a digger. The most important risk factors for colonic diverticula formation are age, especially as patients pass 60, chronic constipation, and colon motility disorders. This is because with these types of conditions, the colon has to increase the pressure it uses to move the stool along. Age is also important. The longer the colon has been exposed to increased pressures, the more likely you are to have a diverticula. Well, now, thinking about our clinical case, doesn't that sound like Theodore? He's 63 and has a history of constipation. Interestingly, diverticulosis is very common for people on a Western diet. Turns out 50% of people with a Western diet will have a diverticula by the age 50, and 70% by the age 70. However, it's much less likely in people that have higher fiber diets and lower fat diets. This all gets into the mechanics of the colon, with high fat, low fiber stool being, well, mushier, and how the colon shapes each turd into a turd shape. What? Oh, we can't say turds on the air? Well, what good is that? Turds, 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 poop, poop, poop. I win. Risk factors for complications, such as diverticulitis, are largely modifiable. These include a high fat, low fiber diet, like we just talked about, smoking, and obesity. And while it used to be thought that seeds and nuts may obstruct diverticular lumen and cause infection, this has been debunked. So, Eat all the sunflower seeds and pistachios you want. Almost 80% of colonic diverticula occur in the left colon, especially the sigmoid colon, and most cases of diverticulitis occur in the left colon as well. Again, this has to do with more pressure in the colon being needed to propel hard stool through this area. So, how does a diverticulum become infected? I mean, as before, they are usually literally covered in stool and do just fine. It may be that high intraluminal pressure and fecal material within the diverticula itself break down the mucosa, causing a microperforation, which allows a teeny tiny microscopic amount of stool to get inside the colon wall and even a little outside the colon wall. The feces and bacteria trigger inflammation along and throughout the colon wall, which can lead to focal necrosis. The deterioration in the bowel wall can eventually progress to macroperforation, which is a real full blown perforation, which can cause purulent or even feculent peritonitis. In most cases, the body does a good job of containing the inflammation to the affected diverticulum by walling it off with mesenteric fat. Patients may experience this as a mild discomfort. Usually, it won't bring them into the doctor, but they may tell you about it later if they have a more intense attack in the future. Hey, Mo, don't do that. You'll get burned and split thickness skin grafts haven't been invented yet. Okay, I swear that was the last one. However, in some cases, inflammation and perforation can't be contained, and the patient develops acute diverticulitis. The classic presenting symptoms of acute diverticulitis are abdominal pain, usually in the left lower quadrant, just like Theodore from our clinical case, nausea and vomiting, low grade fever, and ileus as inflammation progresses. Oh, geez. This wagon is going to hell in a handbasket. These damn bandits. And thinking back to our clinical case, old Theo presented with these symptoms too. If inflammation spreads and the bladder is affected, patients may experience urinary urgency, frequency, and even dysuria as well. The majority of patients with acute diverticulitis experience bowel changes leading up to presentation. The most common is constipation, though diarrhea is possible as well. On physical exam, patients typically have tenderness to palpation. In some cases, there may even be a palpable mass. Well, the textbook says mass, but it's more like a swelling or like bulging. Not so much a definable hard mass in the affected area due to colonic inflammation and accumulation of mesenteric fat as it tries to wall off said inflammation. Need I say it again? Just like our clinical case. All right, well, it definitely seems like we're on the trail of this diagnosis. Whew, or should I say the organ trail? uh, Based on what we've heard so far, I'd say we have the answer to our clinical question. Diverticulitis seems like it's the most likely diagnosis, but we're so close to reaching the finish line of this trail that we should carry on talking about diagnosis and management of acute diverticulitis until we reach the end. So, how can we confirm this diagnosis? Labs are typically what you'd expect them to be for an inflammatory infectious process. And while leukocytosis is most common, up to 45% of patients have a normal white count. The diagnosis of acute diverticulitis is made using CT, often with IV and oral contrast. PO contrast can collect in the little diverticular pouches, suggesting that the patient probably has diverticulosis in the first place. In the affected segment, look for bowel wall thickening and so called fat stranding, which is just a hypodense appearance of fat due to edema and inflammation in the area. It looks kind of hazy, like a cloud. However, it's important to remember that the presence of diverticula can only be confirmed on colonoscopy. But with active inflammation, performing colonoscopy can be dangerous and lead to perforation of the colon. For that reason, the diagnosis is technically presumed based on CT scan findings, and later, after the inflammation has died down, colonoscopy is performed to confirm diverticula and to rule out colon cancer. CT findings also help guide subsequent treatment. In most cases, acute diverticulitis is simple, i.e., uncomplicated, and contained to the affected bowel segment. However, if CT shows one of the complications of diverticulitis, the most common being abscess, obstruction, perforation, or fistula formation, it's, well, more complicated. They call that complicated acute diverticulitis, and it only occurs in about 15% of cases. Appropriate patients with mild, uncomplicated diverticulitis can actually be treated as outpatients with 7 to 10 days of PO antibiotics. The most common regimen to cover the most likely organisms, that is, GI flora and anaerobes, is a combination of ciprofloxacin and metronidazole. Severe diverticulitis, or complicated diverticulitis, on the other hand, requires more extensive treatment. The term complicated diverticulitis refers typically to abscess, fistula, or perforation associated with the diverticulitis. Typically, these patients are admitted to the hospital and put on bowel rest, or at least clear liquids, depending on how nauseated they are. In almost all cases of complicated diverticulitis, IV antibiotics are given. These can be the same ciprofloxacin and metronidazole as for outpatient treatment, though broader coverage is indicated in some situations. One of the most common complications of acute diverticulitis is abscess formation, which can occur in 20 to 60% of patients with complicated diverticulitis. As with all abscesses, the preferred method of treatment is drainage. Since abscesses due to diverticulitis occur in the abdomen or deep in the pelvis, surgery used to be required for all deep abscesses secondary to acute diverticulitis. However, CT guided percutaneous drainage can now be used to evacuate the nastiness. Catheters are typically left in place until drainage stops, which can sometimes take up to a month. And while most are placed through the abdominal wall, transrectal approaches may be considered in certain anatomic situations. If the abscess can't be drained with the catheter, usually because it's too small or in a bad location to hit with the catheter, a few days of IV antibiotics can be attempted. If there's no resolution after a week, surgical evacuation may be required. Given enough inflammation during diverticulitis, a fistula, i.e., abnormal tract connecting two epithelialized structures, may develop. A colovesical fistula, which connects the colon and the bladder, is the most common fistula seen following diverticulitis, especially in men. Typical signs of colovesical fistula development include dysuria, burning or pain with urination, pneumaturia, which is air in the urine stream, and even fecal uria, stool in the urine. Gross. Needless to say, patients with the colovesical fistula are prone to recurrent UTIs. In women, because other lady parts exist between the colon and the bladder, colovesical fistulas are less common. Instead, women may develop colovaginal fistulas. Elective surgical correction is indicated after fistula development has been diagnosed. In some cases, patients may present with large bowel obstruction secondary to diverticulitis. While diverticulitis typically doesn't cause complete obstruction, it can be bad enough to warrant surgical resection of the affected portion of the bowel. In an unlucky 1%, acute diverticulitis progresses to frank perforation of the bowel wall. When there's spillage into the abdominal cavity, patients may develop purulent, pus peritonitis, or even feculent, poop peritonitis. Frank perforation can be seen on CT scan, usually where there's bubbles of air in the abdominal cavity, where there isn't supposed to be bubbles of air. But unless there are balls of stool in the abdomen, it's nearly impossible to tell the difference between purulent and feculent peritonitis on CT scan. Those are a finding made at the time of surgery. While peritonitis is very common with frank perforation and can be suggested on CT scan, remember that it's a clinical finding with the classic signs of guarding, rigidity, and rebound tenderness on exam. An interesting side note: way back before they had CT scans, for instance in the 1800s on the Oregon Trail, there was a classification system to grade complicated diverticulitis at the time of surgery. This is called the Hinchy classification, and it's been modified to be used in this day and age with the use of CT scan. Hinchy 1 is an abscess formed next to the inflamed part of the colon. Hinchy 2 is an abscess, usually still in the pelvis, but further away or distant from the inflamed colon segment. And Hinchy 3 and 4 are perforation with purulent and feculent peritonitis, respectively. Again, you can't tell these apart on CT scan, but it helps with decisions made intraoperatively. The treatment for perforation following diverticulitis is the same as perforation due to any other bowel pathology: surgery. And patients with severe diverticulitis that isn't responding to medical therapy may also require surgery. We're talking urgent or emergent surgery. The affected portion of colon is removed, but because there's spillage of either pus or stool into the abdominal cavity, there is severe inflammation. When there's a lot of inflammation, there's always a concern that a primary anastomosis, or reconnection of the two ends of the colon, will not heal properly and instead perforate and cause peritonitis again. For this reason, when severe inflammation is present, such as with purulent or feculent peritonitis, a Hartmann's procedure is performed. A Hartmann's procedure, aka proctosigmoidectomy, involves removing the sigmoid colon and proximal rectum. In the case of diverticulitis, this should contain the affected segment of colon, so it may involve the whole left colon. This may result in resection of much or all of the left colon, also known as a left hemicolectomy. In these cases, the rest of the steps in Hartmann's procedure still applies. The remaining rectum left in place is closed usually with staples proximally, creating a rectal stump also called a Hartmann's pouch. The proximal colon is brought up and an end colostomy is created through the abdominal wall. This allows the patient to recover from the acute illness, which may be severe, such as sepsis or septic shock. The benefits of a Hartmann's procedure include shorter operating time, which is always beneficial to sick patients who can't tolerate anesthesia for prolonged times, as well as not having to worry about an anastomotic breakdown and a new perforation. After recovery, the colostomy can be reversed, restoring bowel continuity, typically 3 to 6 months after recovery. You can remember the natural history of diverticulitis with the rule of thirds. After the first episode of acute diverticulitis, 1/3 of patients have total resolution without recurrence of diverticulitis. 1/3 have occasional episodes of pain, which may or may not be brought to the attention of medical professionals. And 1/3 go on to have recurrence of an acute diverticulitis attack. But after a second attack, it's most likely that the patient will go on to have more attacks. Surgery for diverticulitis isn't limited to emergent or urgent surgery. Elective surgery may be performed after a single complicated bout of diverticulitis or after the first recurrence of uncomplicated diverticulitis. No one wants to be cutting colon out unnecessarily. But the rate of recurrence and complications is too high in some patients not to pursue elective resection. Plus, elective surgery allows for resection of the affected colon with primary anastomosis, thus ensuring bowel continuity and thus obviating the need for an end colostomy. Of course, remember that intraoperative decision making in surgery is difficult, and patients still may require a temporary diverting loop ileostomy. Finally, a word about follow up. Colonoscopy should be performed about 6 weeks after an episode of acute diverticulitis, except in cases of surgery where that's going to depend on what surgery and how the patient heals after surgery. The scoping serves two functions: confirming the presence of diverticula and ruling out colon cancer, which can mimic diverticulitis on rare occasion, especially in cases presenting as obstruction. So, after our clinical patient Theodore recovers, he's gonna need a colonoscopy. All right, we got through diverticulitis, everyone. Let's sum all this up. Colonic diverticula are outpouchings of colonic mucosa which herniate through the bowel wall at weak points formed by the penetrating vasa recta from the mesentery. These diverticula contain only mucosa and submucosa, and thus are considered false diverticula. The risk factors for having diverticula are increased age, chronic constipation, and chronic motility disorders. Importantly, diverticulosis has a very strong association with the Western diet of high fat, low fiber foods, which is thought to make stool transit through the colon require more pressure from the colon wall. More pressure equals more herniation. Along with the high fat, low fiber diet, like diverticulitis, some risk factors increase the complications from diverticulosis. These risk factors are obesity, smoking, and the high fat, low fiber diet. The most common location of colonic diverticula is in the sigmoid colon. Diverticulitis develops from inflammation of the diverticula, which is thought to be due to stool or bacteria and high pressure breaking down the mucosa, leading to microperforation of the diverticula. After these microperforations, bacteria escape outside the colon wall and cause inflammation in and along the colon wall. Usually, this perforation is walled off by mesenteric and omental fat. In other situations, this inflammation can progress to full perforation. Diverticulitis presents typically with left lower quadrant pain. Patients may also present with nausea, emesis, fever, ileus, and symptoms of bladder irritation like frequency, urgency, and dysuria. Patients may also have a history of changes in bowel habits for a few days prior to presentation. Usually this is constipation, but diarrhea is also possible. Patients often have tenderness in the left lower quadrant. Patients may have leukocytosis and other markers of inflammation. CT scans should demonstrate signs of inflammation of the colon, including bowel wall edema and thickening, presence of diverticula, and mesenteric fat stranding. Mild cases of uncomplicated diverticulitis may be treated as an outpatient with 7 to 10 days of oral antibiotics, typically ciprofloxacin and metronidazole. Severe or complicated diverticulitis, which means diverticulitis with abscess, fistula, or perforation, requires hospital admission with IV antibiotics and bowel rest. If an abscess is present, percutaneous drainage until the abscess has resolved is the typical treatment. If the abscess is not amenable to percutaneous drainage, then surgery may be required if the abscess does not resolve with antibiotics alone. Fistulization to other abdominopelvic organs is also possible, with the most common being a colon to bladder fistula, called colovesical fistula. This often presents with dysuria and recurrent UTIs, pneumaturia, and even fecal uria. This is most common in men, as most women have a uterus and vagina between their rectum and bladder. Women may get colovaginal fistulas in these cases. Surgery is the required treatment. Diverticulitis may also cause large bowel obstruction, usually partial obstruction and not complete. Surgery may be required in severe cases. Diverticulitis may also result in frank perforation, leading to purulent or feculent peritonitis. Abscess and perforation are classified based on the Hinchey classification system for truly acute diverticulitis. Though a severe complication, fistulization is not a typical initial presentation of acute diverticulitis. There usually needs to be continued inflammation of development of fistulization. For perforation and surgical intervention for acute diverticulitis, typically a Hartmann's procedure is performed. This involves removal of the affected portion of the colon, including the sigmoid and rectum, stapling off the rectal stump, and then creating an end colostomy. Patients presenting with an episode of diverticulitis have three paths for possible recurrence. And easy to remember, it's divided into thirds. One third will have no recurrence of diverticulitis, one third will have episodic pain, and one third will have full recurrence of another episode of diverticulitis. Due to the high rate of recurrence in some patients, like patients with multiple attacks or patients with a single complicated episode of diverticulitis, elective surgery can be performed in between attacks. This allows for primary anastomosis and possible avoidance of an ostomy. Colonoscopy should be performed to confirm that there was diverticula in the first place. But remember, CT scan may suggest the presence of diverticula, but colonic diverticula need to be confirmed on colonoscopy. Great job, everyone! We made it to Oregon. Now we just gotta hit up Patagonia for some jackets and those hipster hats. Oh, and we'll need to learn all about mustache and beard grooming. Should probably just do a whole sketch on that. Oh, and voodoo donuts. Can't forget about those.